Welcome to our deep dive into a clinical scenario that frequently presents a diagnostic challenge, the patient with concurrent anemia and thrombocytopenia. This combination of cytopenias can be the first clue to a wide range of underlying pathologies, from the relatively benign to the life-threatening. For the junior resident, encountering this duo on a complete blood count can be daunting. For the seasoned practitioner, it's a call to systematic evaluation and nuanced clinical reasoning. In this episode, we will meticulously dissect the approach to anemia with thrombocytopenia, providing a comprehensive framework for diagnosis and management that is both evidence-based and clinically practical. We will begin by exploring the fundamental pathophysiology, understanding how and why red blood cell and platelet lineages might fail together. We will then walk through the clinical presentation, highlighting key historical clues and physical examination findings. A significant portion of our discussion will be dedicated to the diagnostic workup, from interpreting the initial labs and peripheral blood smear to deciding when a bone marrow biopsy is imperative. We will cover a broad differential diagnosis, offering pearls to distinguish between the various etiologies. Following this, we will delve into the management of the most common and critical conditions, integrating the latest clinical guidelines and landmark trials. Finally, we will address special populations and advanced insights, ensuring you are equipped with the knowledge to handle even the most complex cases. To begin, let's establish a solid foundation by understanding the pathophysiology behind the simultaneous presentation of anemia and thrombocytopenia. The bone marrow, our hematopoietic factory, is responsible for producing red blood cells, white blood cells, and platelets from a common pool of hematopoietic stem cells. Therefore, any process that disrupts this factory at its core can lead to a combined deficiency. We can broadly categorize the underlying mechanisms into two main buckets: problems with production, and problems with destruction or sequestration. First, let's consider the production problems. A primary failure of the bone marrow is a significant cause of bicytopenia, or even pancytopenia, where all three cell lines are affected. In this scenario, the hematopoietic stem cells themselves are either absent, damaged, or being crowded out. Aplastic anemia is a classic example of a primary bone marrow failure state. This is a rare but serious condition where the bone marrow is hypocellular, essentially empty, due to an autoimmune attack on the hematopoietic stem cells. The result is a profound deficiency in the production of all blood cell lines. Another major category of production problems includes infiltrative diseases of the bone marrow. This is where the normal hematopoietic tissue is replaced by abnormal cells. Acute leukemias, both myeloid and lymphoid, are prime examples. Malignant blasts proliferate uncontrollably within the marrow, suppressing normal hematopoiesis and leading to the release of immature and non-functional cells into the periphery. Similarly, other hematologic malignancies like myelodysplastic syndromes, or MDS, are characterized by ineffective hematopoiesis. In MDS, the bone marrow is often hypercellular, but the cells produced are dysplastic and die before maturing and entering the circulation, resulting in peripheral cytopenias. Lymphomas and solid tumors that metastasize to the bone marrow can also cause a similar infiltrative picture, a condition known as myelophthisis. Infections can also suppress bone marrow production. Viral infections, in particular, are notorious for this. Parvovirus B19 has a direct cytotoxic effect on erythroid precursors, leading to a transient aplastic crisis, which can be particularly severe in patients with underlying hemolytic anemias. Other viruses like Epstein-Barr virus, Cytomegalovirus, and HIV can also cause bone marrow suppression through a variety of mechanisms, including direct infection of hematopoietic cells and immune-mediated destruction. Certain bacterial infections, particularly overwhelming sepsis, can also lead to bone marrow suppression. Nutritional deficiencies are a crucial and often reversible cause of impaired production. Severe deficiencies of vitamin B12 or folate are classic causes of megaloblastic anemia, which can also be associated with thrombocytopenia and even neutropenia. These vitamins are essential for DNA synthesis, and their absence leads to impaired cell division and maturation in the rapidly dividing hematopoietic cells. The bone marrow in these cases is typically hypercellular with characteristic megaloblastic changes. Finally, exposure to toxins and drugs can significantly impair bone marrow function. Chemotherapy and radiation therapy are obvious examples, as they target rapidly dividing cells, including those in the bone marrow. A host of other medications, including certain antibiotics, antiepileptics, and anti-inflammatory drugs, can cause idiosyncratic, dose-independent bone marrow suppression. Alcohol is another common culprit, directly suppressing hematopoiesis. Now let's turn our attention to the second major category of pathophysiology, increased destruction or sequestration of both red blood cells and platelets. In these scenarios, the bone marrow is often working overtime, trying to compensate for the peripheral loss, but is unable to keep up. Immune-mediated destruction is a key player here. Evans syndrome is a rare autoimmune disorder characterized by the simultaneous or sequential development of autoimmune hemolytic anemia and immune thrombocytopenia. In this condition, the body produces antibodies that target and destroy its own red blood cells and platelets. This is often associated with other autoimmune diseases, such as systemic lupus erythematosus, or SLE, and lymphoproliferative disorders. Thrombotic microangiopathies, or TMAs, are a group of life-threatening disorders that cause widespread formation of microthrombi in small blood vessels. This process consumes platelets, leading to profound thrombocytopenia, and shears red blood cells as they pass through the occluded vessels, resulting in a microangiopathic hemolytic anemia, characterized by the presence of schistocytes on the peripheral blood smear. The two classic examples of TMAs are thrombotic thrombocytopenic purpura, or TTP, and hemolytic uremic syndrome, or HUS. TTP is typically caused by a deficiency in the ADAMTS13 enzyme, which is responsible for cleaving von Willebrand factor. Without this enzyme, large von Willebrand factor multimers accumulate, leading to spontaneous platelet aggregation and microthrombus formation. HUS is often associated with Shiga toxin-producing E. coli infections, particularly in children, and is characterized by a triad of microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury. Hypersplenism is another important cause of combined anemia and thrombocytopenia. The spleen acts as a filter for the blood, and when it becomes enlarged, it can sequester a large proportion of the circulating red blood cells and platelets, leading to peripheral cytopenias. The most common cause of hypersplenism is liver cirrhosis with portal hypertension. In this setting, the bone marrow is typically hypercellular, as it is trying to compensate for the peripheral sequestration. Understanding these fundamental pathophysiological mechanisms is crucial because it provides a framework for our diagnostic approach. When we encounter a patient with anemia and thrombocytopenia, we need to ask ourselves, is this a problem of production, a problem of destruction, or a combination of both? The answer to this question will guide our subsequent investigation. Now that we have a solid understanding of the underlying pathophysiology, let's move on to the clinical presentation of a patient with anemia and thrombocytopenia. The signs and symptoms will often be a combination of those related to each cytopenia, as well as clues that point towards a specific underlying etiology. Let's first consider the symptoms of anemia. These are largely due to decreased oxygen-carrying capacity of the blood. Patients may complain of fatigue, weakness, and exertional dyspnea. They may appear pale, with pallor of the conjunctivae, nail beds, and palmar creases. In more severe cases, patients may experience tachycardia, palpitations, and even angina, especially if they have underlying coronary artery disease. A flow murmur may be audible on cardiac auscultation due to the hyperdynamic circulation. Next, let's look at the signs and symptoms of thrombocytopenia. These are related to impaired hemostasis and an increased risk of bleeding. Patients may present with petechiae, which are pinpoint, non-blanching red or purple spots on the skin, often found in dependent areas. Purpura, which are larger areas of bleeding under the skin, and ecchymoses, or bruises, may also be present. Patients may report epistaxis, or nosebleeds, and gingival bleeding, especially after brushing their teeth. Menorrhagia, or heavy menstrual bleeding, is a common complaint in women. In severe thrombocytopenia, there is a risk of more serious bleeding, such as gastrointestinal hemorrhage, which can manifest as melena or hematochezia, and intracranial hemorrhage, which can present with headache, altered mental status, or focal neurological deficits. It is crucial to take a detailed history to uncover clues that may point to the underlying cause of the combined cytopenias. A thorough review of systems is essential. The presence of fever, night sweats, and unintentional weight loss should raise suspicion for an underlying malignancy, such as leukemia or lymphoma, or a chronic infection. A history of autoimmune disease, such as systemic lupus erythematosus or rheumatoid arthritis, may suggest an immune-mediated process like Evans syndrome. A detailed medication history is also critical, as many drugs can cause bone marrow suppression. It is important to ask about both prescription and over-the-counter medications, as well as herbal supplements. A social history should include questions about alcohol consumption, as this is a common cause of bone marrow suppression, and any potential occupational or environmental exposures to toxins like benzene. A family history of blood disorders may suggest an inherited bone marrow failure syndrome, such as Fanconi anemia, although these typically present in childhood. The physical examination can also provide valuable clues. In addition to assessing for pallor and signs of bleeding, it is important to look for lymphadenopathy and hepatosplenomegaly. Enlarged lymph nodes can be a sign of lymphoma or a systemic infection. An enlarged liver or spleen can be seen in a variety of conditions, including hematologic malignancies, portal hypertension with hypersplenism, and some infections. A thorough neurological examination is important, as focal deficits or altered mental status could indicate a thrombotic microangiopathy or an intracranial bleed. Bony tenderness, particularly over the sternum, may be a sign of a packed bone marrow, as seen in acute leukemia. It is also important to consider the acuity of the presentation. A patient presenting with rapidly developing, severe cytopenias and signs of bleeding or infection is a medical emergency and requires immediate evaluation and management. In contrast, a patient with mild, chronic, and stable cytopenias may be evaluated in the outpatient setting. The combination of a thorough history and physical examination will often allow you to start narrowing down the differential diagnosis and guide your subsequent diagnostic workup, which we will discuss in detail next. The diagnostic workup for a patient with anemia and thrombocytopenia is a systematic process that begins with a careful review of the initial laboratory tests and peripheral blood smear, and may culminate in a bone marrow examination. The goal is to not only confirm the cytopenias but also to identify clues that will lead to the underlying diagnosis. The first step is always to review the complete blood count, or CBC, with differential. This will confirm the presence and severity of the anemia and thrombocytopenia. It is also important to look at the white blood cell count. The presence of pancytopenia, where all three cell lines are decreased, significantly narrows the differential diagnosis to conditions that affect the entire bone marrow, such as aplastic anemia, leukemia, or severe nutritional deficiencies. On the other hand, if the white blood cell count is normal or elevated, it may point towards a process that is more specific to the red blood cell and platelet lineages. The mean corpuscular volume, or MCV, is another important parameter. A high MCV, or macrocytic anemia, is characteristic of megaloblastic anemias due to vitamin B12 or folate deficiency, as well as myelodysplastic syndromes and liver disease. A low MCV, or microcytic anemia, is most commonly due to iron deficiency, although this is less frequently associated with thrombocytopenia. A normocytic anemia is seen in a wide variety of conditions, including anemia of chronic disease, aplastic anemia, and hemolytic anemias. The reticulocyte count is a crucial next step in the evaluation of anemia. This measures the number of young red blood cells being released from the bone marrow and is a reflection of the bone marrow's response to the anemia. A low reticulocyte count in the setting of anemia indicates a problem with red blood cell production, pointing towards a primary bone marrow disorder. A high reticulocyte count, in contrast, suggests that the bone marrow is trying to compensate for peripheral red blood cell destruction or loss, as seen in hemolytic anemias or acute blood loss. A careful examination of the peripheral blood smear by an experienced hematologist or pathologist is perhaps the single most important diagnostic test in the initial workup. It can provide a wealth of information that is not available from the automated CBC. The smear should be examined for abnormalities in all three cell lines. In the red blood cell series, the presence of schistocytes, or fragmented red blood cells, is a hallmark of microangiopathic hemolytic anemia and should prompt an urgent evaluation for a thrombotic microangiopathy. Spherocytes may suggest an autoimmune hemolytic anemia. Target cells can be seen in liver disease and hemoglobinopathies. The presence of macroovulocytes and hypersegmented neutrophils is classic for megaloblastic anemia. In the white blood cell series, the presence of circulating blasts is a critical finding that is highly suggestive of acute leukemia. Dysplastic changes in the neutrophils, such as hyposegmentation or hypogranulation, are features of myelodysplastic syndromes. In the platelet series, the presence of giant platelets may suggest an inherited thrombocytopenia or a destructive process like immune thrombocytopenia. Once you have reviewed the CBC and peripheral blood smear, the next set of laboratory tests will depend on the suspected underlying etiology. If a destructive process is suspected, a hemolysis panel should be ordered, which includes a lactate dehydrogenase, or LDH, level, an indirect bilirubin level, and a haptoglobin level. An elevated LDH and indirect bilirubin, along with a low haptoglobin, are consistent with hemolysis. A direct antiglobulin test, or DAT, also known as a Coombs test, should also be performed to look for evidence of antibody-mediated red blood cell destruction, as seen in autoimmune hemolytic anemia. If a nutritional deficiency is suspected, serum vitamin B12 and folate levels should be measured. It is also important to check iron studies, including serum iron, total iron binding capacity, and ferritin, as iron deficiency can sometimes be associated with thrombocytopenia, although thrombocytosis is more common. Liver function tests and a coagulation panel, including a prothrombin time, or PT, and an activated partial thromboplastin time, or APTT, are also important. Liver disease can cause both anemia and thrombocytopenia through a variety of mechanisms, including hypersplenism and impaired production of thrombopoietin. An abnormal coagulation panel may suggest disseminated intravascular coagulation, or DIC, which is a consumptive coagulopathy that can be seen in sepsis, malignancy, and other critical illnesses. If a thrombotic microangiopathy is suspected, an urgent ADAMTS13 activity level should be sent to evaluate for TTP. A stool culture for Shiga toxin-producing E. coli should be performed if HUS is a consideration, particularly in a patient with a history of diarrheal illness. In many cases, a bone marrow aspiration and biopsy will be necessary to establish a definitive diagnosis, particularly when a primary bone marrow disorder is suspected. This is an invasive procedure, but it provides invaluable information about the cellularity of the bone marrow, the the morphology of the hematopoietic cells, and the presence of any abnormal infiltrates. A bone marrow biopsy is indicated in patients with unexplained bicytopenia or pancytopenia, particularly if there are circulating blasts on the peripheral smear, or if other less invasive tests have not yielded a diagnosis. The bone marrow ASPI rate is examined for the percentage of blasts, the presence of dysplasia, and the iron stores. The biopsy provides information about the overall cellularity of the marrow and can reveal fibrosis or infiltration by non-hematopoietic cells. Cytogenetic analysis and flow cytometry can also be performed on the bone marrow sample to look for chromosomal abnormalities and to immunophenotype the cells, which is essential for the diagnosis and classification of leukemias and myelodysplastic syndromes. The differential diagnosis for a patient with anemia and thrombocytopenia is broad and can be organized based on the underlying pathophysiological mechanism. Thinking in terms of production problems versus destruction problems can be a helpful framework. Let's start with the production problems, which are often associated with a hypocellular bone marrow or a marrow that is infiltrated with abnormal cells. Aplastic anemia is a key consideration, especially in a young patient with pancytopenia and a hypocellular bone marrow on biopsy. Myelodysplastic syndromes are another important cause, particularly in older adults. In MDS, the bone marrow is often hypercellular, but the cells are dysplastic and die before maturing. Acute leukemias, both myeloid and lymphoid, can present with pancytopenia due to the replacement of normal hematopoietic tissue with malignant blasts. Lymphomas and solid tumors that metastasize to the bone marrow can also cause a similar picture. Infections are a common cause of bone marrow suppression. Parvovirus B19, Epstein-Barr virus, Cytomegalovirus, and HIV should all be considered. Severe bacterial sepsis can also lead to bone marrow suppression. Nutritional deficiencies, particularly severe vitamin B12 and folate deficiency, are a classic cause of combined anemia and thrombocytopenia, often with pancytopenia. These are important to recognize as they are readily treatable. Exposure to drugs and toxins is another major category of production problems. A careful medication history is crucial to identify any potential offending agents. Alcohol is a common and often overlooked cause of bone marrow suppression. Now let's turn to the conditions that cause increased peripheral destruction or sequestration of red blood cells and platelets. These are often associated with a hypercellular bone marrow, as the marrow is trying to compensate for the peripheral loss. Immune-mediated destruction is a key mechanism in this category. Evans syndrome, which is the combination of autoimmune hemolytic anemia and immune thrombocytopenia, is a classic example. This can be idiopathic or associated with other autoimmune diseases like SLE or lymphoproliferative disorders. Thrombotic microangiopathies are a group of life-threatening disorders that cause both thrombocytopenia and a microangiopathic hemolytic anemia. TTP and HUS are the two most important entities in this category. Other conditions that can cause a TMA-like picture include DIC, malignant hypertension, and certain drugs. Hypersplenism is another important cause of combined anemia and thrombocytopenia due to sequestration. This is most commonly seen in patients with liver cirrhosis and portal hypertension, but can also be caused by other conditions that lead to splenomegaly, such as hematologic malignancies and storage diseases. Distinguishing between these various etiologies requires a systematic approach that integrates the clinical presentation, laboratory findings, peripheral blood smear, and, in many cases, a bone marrow examination. The acuity of the presentation and the severity of the cytopenias will also help to guide the diagnostic and therapeutic approach. Now, let's delve into the management of some of the key conditions that present with anemia and thrombocytopenia. The treatment will, of course, be highly dependent on the underlying diagnosis. Let's start with aplastic anemia. The management of severe aplastic anemia depends on the patient's age and the availability of a matched sibling donor for hematopoietic stem cell transplantation. For younger patients, typically those under the age of 40 or 50, allogeneic stem cell transplantation from a matched sibling donor is the treatment of choice and offers the best chance of a cure. For older patients, or those without a matched sibling donor, the standard of care is immunosuppressive therapy, typically with a combination of antithymocyte globulin, or ATG, and cyclosporin. This therapy aims to suppress the autoimmune attack on the hematopoietic stem cells and allow for the recovery of bone marrow function. More recently, the thrombopoietin receptor agonist L-trombopag has been added to this regimen, and a landmark trial published in the New England Journal of Medicine in 2022 showed that the addition of L-trombopag to standard immunosuppressive therapy resulted in higher rates of hematologic response and improved event-free survival in patients with severe aplastic anemia. Supportive care is also a critical component of management and includes red blood cell and platelet transfusions as needed, as well as prophylactic antibiotics and antifungals to prevent infections in neutropenic patients. For patients with acute leukemia, the treatment is a medical emergency and requires immediate initiation of induction chemotherapy. The specific chemotherapy regimen will depend on the type of leukemia, whether it is acute myeloid leukemia, or AML, or acute lymphoblastic leukemia, or all, as well as the patient's age and comorbidities. The goal of induction chemotherapy is to achieve a complete remission, which is defined as the absence of leukemia cells in the bone marrow and the recovery of normal hematopoiesis. This is typically followed by consolidation therapy, which may include further cycles of chemotherapy or an allogeneic stem cell transplant, to prevent relapse. The management of acute leukemia is complex and should be overseen by a hematologist-oncologist at a specialized center. The management of myelodysplastic syndromes is more varied and depends on the subtype of MDS, the patient's risk stratification score, and their overall health status. For lower-risk MDS, the focus is on supportive care with transfusions and growth factors like erythropoiesis-stimulating agents to manage the cytopenias. For higher-risk MDS, the goal is to slow the progression to acute leukemia and improve survival. The hypomethylating agents azacitidine and decitabine are the mainstay of treatment for higher-risk MDS. For younger, fit patients, an allogeneic stem cell transplant may be considered as it is the only potentially curative option. In the case of a thrombotic microangiopathy like TTP, urgent management is critical to prevent irreversible organ damage and death. The cornerstone of treatment for TTP is therapeutic plasma exchange, or PEX. This procedure removes the patient's plasma, which contains the autoantibodies against ADAMTS13 and the large von Willebrand factor multimers, and replaces it with fresh frozen plasma, which replenishes the deficient ADAMTS13 enzyme. PEX should be initiated as soon as TTP is suspected, even before the ADAMTS13 level is back. Immunosuppressive therapy with corticosteroids is also started concurrently. In recent years, the monoclonal antibody caplacizumab, which targets the A1 domain of von Willebrand factor and inhibits platelet adhesion, has been shown to be a valuable addition to the treatment of TTP. The Hercules trial, published in the New England Journal of Medicine in 2019, demonstrated that the addition of caplacizumab to standard therapy resulted in a faster time to platelet count normalization and a lower rate of TTP-related death, recurrent TTP, or a major thromboembolic event. For patients with Evans syndrome, the treatment is aimed at suppressing the autoimmune response. High-dose corticosteroids are the first-line therapy. For patients who do not respond to corticosteroids or who relapse, other immunosuppressive agents such as rituximab, a monoclonal antibody that targets B cells, may be used. In refractory cases, splenectomy may be considered. Finally, for patients with anemia and thrombocytopenia due to a nutritional deficiency, the treatment is simply to replete the deficient vitamin. For vitamin B12 deficiency, intramuscular or subcutaneous injections of vitamin B12 are typically given initially to bypass any potential absorption issues, followed by oral supplementation. For folate deficiency, oral folic acid supplementation is usually sufficient. It is important to remember to always replete vitamin B12 before folate in a patient with megaloblastic anemia, as giving folate alone in a B12 deficient patient can precipitate or worsen neurological complications. As we move into the more advanced aspects of our discussion, it's crucial to consider how the presentation and management of anemia with thrombocytopenia can differ in special populations. These nuances are key to providing optimal care. Let's first consider pediatric patients. The differential diagnosis in children is different from that in adults. Inherited bone marrow failure syndromes, such as Fanconi anemia, Diamond-Blackfan anemia, and Shwachman-Diamond syndrome, are more common in this age group. These are often associated with characteristic physical anomalies and should be considered in any child presenting with cytopenias. Acute lymphoblastic leukemia is the most common malignancy in children and frequently presents with anemia and thrombocytopenia. Immune thrombocytopenia, or ITP, is also common in children, but it is usually a self-limited post-viral illness, in contrast to the more chronic course often seen in adults. Hemolytic uremic syndrome is another important consideration in children, particularly in the setting of a diarrheal illness. The workup in a child with anemia and thrombocytopenia often includes genetic testing for inherited bone marrow failure syndromes, in addition to a bone marrow examination. The management of these conditions in children is highly specialized and should be handled by a pediatric hematologist-oncologist. Next, let's turn our attention to geriatric patients. The elderly are more likely to have multiple comorbidities and be on multiple medications, which can complicate the diagnostic and therapeutic picture. Myelodysplastic syndromes and acute myeloid leukemia are much more common in older adults. Nutritional deficiencies are also more prevalent in this population. The management of hematologic malignancies in the elderly can be challenging, as they are often less able to tolerate intensive chemotherapy. The decision to pursue aggressive treatment versus a more supportive care approach must be individualized, taking into account the patient's functional status, comorbidities, and personal preferences. Pregnancy is another special situation where the presentation of anemia and thrombocytopenia requires careful consideration. Gestational thrombocytopenia is a benign condition of pregnancy that typically occurs in the third trimester and resolves after delivery. However, it is a diagnosis of exclusion. More serious conditions that can present with anemia and thrombocytopenia in pregnancy include preeclampsia with severe features and the HELLP syndrome, which stands for hemolysis, elevated liver enzymes, and low platelets. These are life-threatening conditions for both the mother and the fetus and often necessitate delivery. Immune thrombocytopenia can also occur in pregnancy and may require treatment to increase the platelet count before delivery to reduce the risk of bleeding. A thrombotic microangiopathy, such as TTP or atypical HUS, can also be triggered by pregnancy and requires urgent management. In terms of current controversies and areas of ongoing research, there is a great deal of interest in developing more targeted and less toxic therapies for hematologic malignancies and bone marrow failure states. The use of next-generation sequencing to identify specific genetic mutations in conditions like MDS and AML is becoming more common and is helping to guide the use of targeted therapies. The role of the microbiome in modulating the immune system and its impact on conditions like aplastic anemia and graft-versus-host disease after stem cell transplantation is another exciting area of research. There is also ongoing research into the development of novel therapies for thrombotic microangiopathies, including new agents that target different aspects of the coagulation cascade. Finally, I'd like to share some practical pearls for the seasoned clinician. First, never underestimate the power of a well-performed peripheral blood smear review. It can often provide the diagnosis or at least significantly narrow the differential in a matter of minutes. Second, always maintain a high index of suspicion for a thrombotic microangiopathy in a patient with unexplained anemia and thrombocytopenia, especially if there is any evidence of organ dysfunction. Delaying treatment in TTP can be fatal. Third, remember to consider common and reversible causes, such as alcohol and nutritional deficiencies, before embarking on an extensive and expensive workup. And lastly, a multidisciplinary approach is often necessary in the management of these complex patients. Collaborating with hematologists, pathologists, and other specialists is key to providing the best possible care. In conclusion, the patient with anemia and thrombocytopenia presents a fascinating diagnostic challenge that requires a systematic and thoughtful approach. By understanding the underlying pathophysiology, performing a thorough clinical evaluation, and utilizing the appropriate diagnostic tests, we can arrive at an accurate diagnosis and initiate the right treatment. Let's summarize the key take-home points from our discussion today. First, the differential diagnosis for anemia with thrombocytopenia is broad and can be categorized into problems with bone marrow production and problems with peripheral destruction or sequestration. A low reticulocyte count points towards a production problem, while a high reticulocyte count suggests a destructive process. Second, a careful review of the peripheral blood smear is the single most important initial diagnostic step. The presence of schistocytes should raise immediate concern for a thrombotic microangiopathy, while circulating blasts are a hallmark of acute leukemia. Third, a bone marrow examination is often necessary for a definitive diagnosis, particularly when a primary bone marrow disorder is suspected. It provides crucial information about cellularity, morphology, and the presence of abnormal infiltrates, and allows for cytogenetic and flow cytometric analysis. Fourth, the management of anemia and thrombocytopenia is highly dependent on the underlying cause. Urgent intervention is required for life-threatening conditions such as acute leukemia and thrombotic thrombocytopenic purpura. And finally, always consider the patient's age and clinical context. The differential diagnosis and management strategies can vary significantly in pediatric, geriatric, and pregnant patients. Thank you for joining me for this in-depth exploration of the approach to anemia with thrombocytopenia. I hope this discussion has provided you with a clear and practical framework that you can apply in your clinical practice.